A very warm welcome from my side for Medical Affairs via Medical. And I'm happy that I can pronounce a second webinar in a row about the new guidelines already published 2 years ago in 2019 from the ERS and ATS. In this row of webinars, next month we will have a webinar about broncho challenge. And again, very happy that I can introduce to you Dr. Graham, who is the first author of this article, of this very extensive publication. And I'm happy to pronounce because he also helped us a lot to implement all these guidelines in our software. And I know this was a lot of work for a lot of people also within the company. And without this help, it would be even harder. I will not take a little more of the time of Dr. Graham because there's a lot of to tell, and ideally there will be 15 to 10 minutes of time left at the end of the presentation, so you can all ask your questions. And if there is not enough time, we will try to answer all the questions afterwards by email. So Dr. Graham, please take over the microphone.
Okay, thank you very much. I'm just going to bring my slides up here. And I assume you can see that, Herman, is that?
I can see it.
Correct? Okay, so my slides are up. Well, thank you for the introduction and thank you to Bayer. I really appreciate this opportunity. I just love talking about spirometry. And so here we go. Now, there we go. So potential conflicts of interest. I have received funding for speaker fees and I'm getting a fee from Bayer for this presentation, but I have no financial interests in any pulmonary function or pharmaceutical companies. And so this presentation is really just highlighting the major changes in the spirometry standards. And it's intended for people, and I'm assuming that you're already familiar with conducting spirometry. And so I won't go into too much detail there. So what I'm going to hit, because of the short time we have really of 45 minutes, is just some of the highlights and some of the things that have changed since the last ones. And there were two things that changed with these spirometry standards. And one of them was that in 2005, you'll recall, there was a full set of standards that came out starting with general considerations, and that general considerations document was not updated. So we had to bring some of the information from there into the standards. And one of the things that was in the old document was contraindications, and really the only contraindication, the only hard contraindication was that you shouldn't test within a month of a myocardial infarction. That in fact has changed now to 1 week. And in the new standards, we've got a long list, and I'll let you look at the standards to find them, but there's several types of stresses that are put on the body in spirometry, and there are relative contraindications related to each one of them. And one of the things to remember, though, is that if the patient experiences pain during the maneuver, you stop right away. But the important thing about this is that the contraindications are relative. And that means that spirometry isn't precluded, but they should be considered when you're ordering or performing spirometry. So the decision to conduct spirometry is really made on the basis of the evaluation of the possible benefits and risks for particular patients. And any potential contraindication should be included in the request form for spirometry so that the operator, the person who's conducting spirometry, knows what to look for. And of course, because the contraindications are relative, in a situation where you're working in a clinic that perhaps doesn't do spirometry very often and is rather remote, it might be a lot different than when you're working in a pulmonary function lab where you've got people doing thousands of tests a year and you have ready access to emergency care. Then other types of indications are probably bypassed. Now, we also looked at then equipment and quality assurance. And one of the big changes we have in here is saying that this has to be included in the written protocols for every place that's offering spirometry. You need to have thought about this in advance and have all of your protocols in place for everything from infection control, equipment, quality assurance, bronchodilator responsiveness testing, and reporting. And now what we've also added is within those standards, it's also spirometry operator training and attainment and maintenance of competency that have to be integrated into that service. In terms of the equipment, the first big change was spirometry accuracy, and we specified 2.5%. The calibration syringe accuracy remains at 0.5%, so the combination of the two of them gives a plus or minus 3% accuracy requirement. When we contacted manufacturers and looked at their websites and so on, we found that in most cases, the accuracy specified was 2%. And however, when we were looking at the broad range of spirometry globally, we felt that that this was a better range to use, which allowed people, which did not impede access to spirometry. But if you have a pulmonary function lab, you've probably got higher class equipment or higher grade of equipment, and people who are used to using it, your internal standards are probably going to be better and should be better than this. You should be able to get within 2%. In that type of a situation. The other thing is that daily calibration verification is required for all spirometers, including those that are pre-calibrated at the factory and that cannot be recalibrated in the field. And it really annoys me when I see advertisements for spirometers that say no calibration necessary. Well, you may not be able to calibrate it, but you still must, you absolutely must verify that the calibration is working and that the spirometer is measuring what you think it should be measuring. And so when you're using disposable flow sensors, you need to use a new flow sensor from the supply used for patient tests each day. Now, the daily check for calibration verification is done at 3 different flows, at a low, a medium, and a high flow rate with a 3-liter calibration syringe. And this gets us not only the verification of the volume accuracy, but it also tells us that it's behaving linearly, that we can get this accuracy at low and at high flows. And so if we use a 3-liter calibration syringe, we have to be within 90 mils, and we do it for both expiration and inspiration. And we want to see all of that being verified. And if the spirometer fails the calibration verification, then of course you need to recalibrate. And recalibration is also required by some manufacturers at various intervals, so that at least weekly there has to be a recalibration. In the standards, we've also included a list of some of the common reasons that are there for calibration verification failure, and then what actions you can take if you do fail the calibration verification. Hygiene and infection control was in the old general standards from the 2005. And of course, at the time we did this, it was pre-COVID. And the biggest thing, of course, that we needed to work on in hygiene and infection control was washing hands. And the other part of it, though, is that we said that if you're using disposable gloves, you still need to be hand washing. And not only that, but when the patient comes in to get the test done, they should be given an improved hand disinfectant, a gel or a wipe, on entry into the testing station. Now, of course, COVID has come along, and that's changed a lot in the pulmonary function world. So these things are not included in the 2019 standards. So you need to be aware of what's going on in your particular jurisdiction. But some of the common things that we're seeing are that during pandemic and post-peak pandemic phases, you should have proper protection for the operator, masks, face shields, and other measures to make sure that that the operators are protected. And these recommendations should probably be maintained until COVID-19 is considered to be controlled, or that we're in the post-pandemic phase. So yes, be aware of what's required in your own jurisdiction, because it varies a lot from place to place. So in doing the FVC maneuvers, this is pretty much the same as we had before. You start by washing hands and you prepare the patient. Dispense the hand sanitizer, confirm identification, age, birth, sex, geographic ancestry, and all of the other things you need to have for getting the proper predicted values. You measure weight and height without shoes. You ask about recent activities, medication use, any relative contraindications. And this is a new one that we've added in. You should note the respiratory symptoms. The reason we brought this in is because it's really important for the person interpreting the test to know if there were any changes in the patient's condition at the time they did the spirometry. So it could be as much as a couple of weeks or more since the person was seen by the referring healthcare professional, and you need to put this in context. So you would look for things like cough, wheeze, dyspnea, or cyanosis. For cyanosis, my own personal recommendation, it's not in the standards, but it's what I think should be happening, is that you should always have a pulse oximeter. It's an easy thing to have around. You can put it on the patient, you get an objective measure of oxygen saturation and the heart rate. And you can add that to the notes, and that also is going to help the interpreter of the tests to put the results in context of the patient. So in performing the maneuver, in 2005, there were 3 main phases. Now there's 4. So the first phase is that first breath right up to the top with a pause of less than 2 seconds at TLC. And this is something we've really emphasized more in these guidelines, is coaching people to get to the top. We found that that's something that's just not happening nearly as well as it should be. And so do that extra coaching to get them up. Then there's the expire with the maximal effort, blasting the air out. And the third step is continuing until no more air can be expelled while maintaining an upright posture. And so you coach throughout that. Keep blowing, keep pushing, get all the air out. And it's really important to keep that coaching up, because when you stop coaching and you stop talking, they stop blowing. Now, in the old 2005 guidelines, this was called the end of test. Now it's not the end of test anymore, and I'll get into that more in a moment. And the new part that we've got in here is that the fourth phase is that you inspire with maximal effort until completely full again, and again, coaching up, up, up. And I'll be talking about this a bit more as well. And although this says new, if you look at the 2005 guidelines, all of the graphs in there showed the full circle of the flow volume loop. So it was implied in the old 2000 standards, but we've explicitly got it in the 2019 ones. So in looking at the end of forced expiration rather than the end of test now, and that's what we call it, end of forced expiration, there are 3 different ways that you can determine that the person has breathed all the way out. And 1 is the plateau, 2 is an expiratory time, and 3 is that you expire completely without achieving a plateau. And let's go into them separately. So the first is, and the one that gives you the most confidence that that person has got all the air out, is reaching an alveolar plateau. So previous spirometry guidelines said you had a minimum expiration time of 6 seconds for adults, 3 seconds for children, and that's been eliminated in the new guidelines. We don't need that anymore. And there's good evidence to show that that's not required. So the best indicator that the end of forced expiration has been required is the expiratory plateau, with less than 25 mils of expiration in the last second of expiration. Now, we've also recommended there should be an audible beep, for the system should give that signal to the operator when the plateau is reached. And the reason for this is that I've just seen far too many cases of the person who's the operator staring at the screen instead of looking at the patient. And they're staring at the screen because they're trying to figure out, is it 6 seconds? Did they reach a plateau? If you get that auditory beep, that gives you a better way of spending more time looking at the patient and then looking back to the screen. You've always got to be dividing your attention between the two, and that just helps. So the question is, what is a plateau? Well, the plateau should be measured in the last second of expiration. And too often I've seen it measured in the last second of the volume time graph, which is not necessarily the same thing. So the volume change that we measure for the plateau is from the point where maximal expired volume is first achieved to the point 1 second earlier. That's where you measure the plateau. And so in systems which just measure the end of whatever's been graphed, there could be some zero flow time in there, which is not part of a plateau. And similarly, the forced expiratory time only includes the time from the start of expiration to the point where maximal volume is first achieved. So let's look at some examples. So here's an example of a good blow. The person's blowing out fast, reaches a nice little plateau, actually achieved maximum expired volume at this point. We come back 1 second, there was 11 mils difference. That is a good plateau. So let's look at this example. Here somebody breathed out, and just after 1 second, looks like they might have closed their glottis, and we just get a flat line coming all the way out. So we get a volume time graph. And in some cases, because the graph is out here, they would say, well, here's the end, and we'll go back a second. There was no volume change. That's not a plateau. That's just where the graph happened to be. If we look at the point where maximum expiration was attained, it's way back here. We come back a second, there was a full 1.89 liters exhaled in that last second. So no, that wasn't a plateau. And similarly, the forced expired time was not 7.7 seconds, it was only 1.3 seconds. And so even on the old guidelines, sometimes people would say, well, he met the 6 second criteria because we've got this graph going out past 6 seconds. So the second way that we can accept the end of forced expiration is for people with COPD or obstruction who just take a long time to empty their lungs. And people with COPD can expire for 20 seconds or more without any sign of a plateau. So what we've said is the maximum expiration time is 15 seconds. Now, this was kind of mentioned in the 2005 guidelines, but it wasn't explicit, and we're making it explicit here. So after 15 seconds, you instruct the patient to stop blowing out, take in as big a breath as possible. And of course, they can blow out for more than 15 seconds, but there's really not any important clinical information by extending the test, and you're only giving the patient a lot more grief. Now here we've said we should have a double beep at 15 seconds to signal the operator when the expiration reaches 15 seconds. And especially for a long blow like this, that's where you're at risk of things like a bit of syncope. Patients start to get faint. You really need to be watching that patient really closely and not watching the screen trying to figure out if it's been 15 seconds. So that's why we've got that hint in there. Now, the third part, and this is a bit more complicated, but we've looked at, again, some of the evidence in this regard. And children and some people with restrictive lung disease can empty very quickly. There's little flattening right at the end of the flow volume curve. And so even with continuing pushing, no further gas is attained. And so they have emptied their lungs. It's been less than 15 seconds. They didn't reach a plateau, but they still got empty. And so the way we look at that now is to say, well, if this happens consistently, if they're getting the same volume out every time, then we can accept that they really have reached the end of forced expiration. So, and again, just a reminder, if the patient starts experiencing pain during forced expiration, you stop the test immediately. And similarly, if the patient shows signs of becoming faint or slumping forward, appearing groggy, you stop the test. Now, the other thing that I'd like to mention is that what I've been focusing on, because that's what the new guidelines focused on, was the inspiration and expiration type of protocol. The 2005 guidelines really started with the expiration only protocol. We've still included that. That's still a valid protocol to use. And so the expiration protocol, where the patient inserts the mouthpiece at maximum lung volume, expires to the end of forced expiration, then removes the mouthpiece, that's also an acceptable protocol. It continues to be acceptable under the new guidelines. So just as in the previous ones, we repeat for a minimum of 3 acceptable FEV1 measurements and 3 acceptable FBC measurements. Now the nuance, the difference here is that in the old guidelines, it said 3 acceptable blows or tests. What we've done is to separate that. You don't need to have tests that have both FEV1 and FBC acceptable measurements. You just have to make sure you've got 3 acceptable of each in that case. And so the other thing now that once you have 3 acceptable of each FEV1 and FVC, then you check to see if the repeatability is met, and do more if you need. So we brought in a new table of acceptability and repeatability criteria. I'm going to talk about acceptability and usability. And I'm going to talk about usability in a moment, but what are some of the changes in what's an acceptable maneuver? So the back extrapolated volume, less than 5%, that's the same as before, but now we've changed this to 100 mils instead of 150. And that was based on a large study of adults and children with various lung diseases. And that's required for acceptability for both FEV1 and FVC. I'll talk about usability a little bit later. The next one is in regard to cough. And of course, if there's a cough in the first second of expiration, then FEV1, in order to have a valid FEV1, there must be no cough in the first second. However, if you have a cough in the first second, but continue to blow out right to the bottom, you can get an acceptable FVC. So that's not a requirement for FVC acceptability. If we go down to the last one, they must have no glottis closure after the first second. Now, I really wish we wouldn't have used the term glottis closure. We should have just said early termination. That would have been a much better term and a much better descriptor. And so we really should have no early termination after the first second. Well, if it's occurring after the first second, that's not required for FEV1 acceptability. So they could have blown out and then just suddenly stopped, either a glottis closure that came off the mouthpiece, they just stopped blowing. As long as they got that first second in, we're okay there. But we do require this to happen for the FVC. So for FVC, there must be no early termination. One of the other things, of course, is that we've got 3 different indicators now for end of forced expiration, and you must achieve one of them. And that's not a requirement for FEV1, because again, FEV1, as long as the first second's okay, you can measure an FEV1. But to get to an acceptable FVC, you need to be hitting one of these indicators. Now, here's the last one we brought in, which is that taking that big breath in again at the end. And that's, so we measure how much volume was inspired at the end, following the end of forced expiration, the forced inspiratory vital capacity, FIVC. Now, if the FIVC, if the amount you breathed in is more than what you breathed out, then we know you didn't start at TLC. And so the limits that are being put in is that it's very same to it's the same criteria as for the back extrapolated volume. You must be within either 100 mils or 5% of VC. And that's required for both FEV1 and FVC acceptability. If you don't do this maneuver, then of course it doesn't negate the acceptability, but this becomes a really important internal control of the acceptability of the maneuver. And I'll talk a bit more about that in a second. So the repeatability criteria, these are staying pretty much the same. The 2 largest FVCs within 150 mils, the 2 largest FEV1s within 150 mils for anyone over 6 years of age. There's a bit of a change here for children 6 or less, and that is that they must be within 100 mils or 5% of the higher value, whichever is greater. And similarly for the FEV1. So there's been a bit of a change there. This is a new item that we brought in, which is the a table of the grading system. And the whole point of the grading system is to tell the person interpreting the test what kind of confidence they can have that what's been measured in this system is actually the values that that person has. And we should always, of course, be shooting for a grade A criteria. Now, the thing is, the other part of this is that we've got separate criteria for FEV1 and FVC. We judge them separately. So it is possible to have a grade A FEV1, but not a grade A FVC in the same maneuver. So a grade A is when we have 3 acceptable maneuver measurements of either FEV1 or FVC, and they're within the tolerance. When that's, if that is being met, then that gives us the highest degree of confidence that we've really got a good measurement. B is still pretty good. It says we've got 2 acceptable maneuvers and they're still within tolerance. And as we go down the grades, we see that the tolerance is not being met and the number of acceptable maneuvers is not being met, but there still seems to be at least 1 acceptable maneuver. And so the degree of confidence the interpreter would have would fall as the grading system goes down. Now we get to this usable category, and I'll talk about that on the next slide. But if there's no acceptable maneuvers, but there's still a usable one, then they would get a grade U. And of course, no acceptable, no usable, it's grade F. You need to do it again. So what's meant by usable? So usable values are not acceptable. That's the very first thing you got to emphasize. They're not acceptable, but they are the best attempt that were obtained from on a particular spirometry session. So the best that that patient or that combination of the patient and the interpreter were able to achieve is there. And so that means that if the patient has come in, has done the tests, didn't get anything acceptable, there still could be some information that would be valuable to the interpreter to know. Now, the usable results usually indicate the maneuver was very likely submaximal in flow and or volume. And in that situation, the interpreter has the information that the FEV1 or FVC values are probably at least this much for this patient. So let's look at some examples. So this is an acceptable maneuver for a child age 4. Under the 2005 guidelines, this wouldn't have been acceptable because the child only breathed out for less than 2 seconds. But they've completed their blow. There was no plateau, but the maneuver was completed. The child did empty, and after 3 breaths, it was found to be consistent. And so we did get acceptable measures of FVC from that. Here's another one that wouldn't have been acceptable under the old guidelines. And this is a woman with COPD. And so she blows out, you see the curve coming all the way down, and we can see that all the way out to the end of the graph, there really is no plateau. It doesn't level off. But she breathes out for 15 seconds, and that's enough to get an acceptable FVC measurement. So one of the other things that we talked about in this was cough. And of course, cough in the first second will tell us that the FEV1 is not acceptable. Now, in this particular graph, that's quite an exaggerated cough. You can see this nice flat line, and it's easier to pick out the coughs in there. Here's one right at the 1 second mark, one a little later. Now, of course, cough is always easier to see in the flow volume graph than it is in the volume time graph. So one of the things we have recommended is that there would be a vertical line at the FEV1 level, and you saw it on those previous graphs as well, so that this distance on the volume axis is equal to the FEV1. And so now you can tell at a glance just whether that cough was within the FEV, within the first second or not. And that's another important part of it. So here's another example of cough. If you didn't have this line and just looked at this person blowing out, you'd see, oh yes, there was cough here. But did it happen in the first second? Well, you go over to the volume time graph, and well, there is a little blip here, but it's kind of hard to see. It's a lot easier to separate out when you have that FEV1 marked and well marked. So here's another change from the old guidelines. And so here's someone who was breathing along, took a big breath in, blew out, actually reached a nice plateau, but then took that great big breath in and breathed in about 800 mils more than they breathed out, almost the whole liter difference. So this is an example of a test that is unacceptable. There's not an acceptable FEV1 or FVC measurement because they didn't start at maximum lung volume. However, the data are still usable. And here's an example of where there can be some usable data from this measurement, because as it turns out, both the FEV1 even though it should have been bigger, and the FVC, even though it should have been much bigger, were above the lower limit of normal. So the interpreter says, you know, they have some confidence, they have some information about that patient. They know that the values that were measured are going to be at least within that range. So this big breath in is really important because it gives us that internal control. Without that big breath, this would have looked like an acceptable test and everything would have been accepted. And this is one of the reasons why we've said we really need to have that fourth phase, that great big breath in at the end. We also looked at bronchodilator responsiveness. And what we found is that in many cases, in many different labs and hospitals, the way that people conduct the testing varies quite a bit. And so rather than saying there can only be one way of doing it, what we've said is that if you're conducting bronchodilator responsiveness testing, you must have a written protocol, and it has to include which bronchodilator you used, what dose you used, the method that it was administered, the wait time between when you give the bronchodilator and your first post-bronchodilator maneuver. And in the online supplement, we did publish some sample protocols for using either an MDI or a nebulizer for administering a bronchodilator. We also had to change the bronchodilator responsiveness testing with holding times. So if you're using a SABA, it's 4 to 6 hours. A SAMA, it's 12 hours. The LABAs now 24 hours that you would wait before testing. An ultra LABA is 36 hours, and the LAMAs are 36 to 48 hours. Now you'll notice that these times are actually a little bit shorter than the withholding times for bronchoprovocation testing. And the reason for that is that the bronchodilator effect is not as long as the bronchoprotective effect. And that's why there's a difference in those two withholding times. Another recommendation that we made was that the ATS standardized report form should be the default form. And this slide just shows some of the elements that we want to see there, that the first row of values are always the measured values for that patient. We also show things like the lower limit of normal and the Z score. And we include a graph, which really shows you at a glance where that patient sits in the spectrum, as well as having the graphs. Another option that we had in here was the standardized operator comments. And in the online supplement, we've got a full list of standardized operator comments in each of these areas that relate to the patient condition, that relate to the quality of the maneuver, the bronchodilator responsiveness testing, and the quality of the session as a whole. And the idea here is that there would be a drop-down menu at particular times during the maneuver where the operators would simply select a comment with a single click. And if everything went well and you don't need to enter any comments, it's one click to say no comments or it's there. And this makes it a lot easier for the operator because now the comments are standardized and they're synoptic. You're not writing stories, you're picking out specific details. And that's an important part of it. So here's an example. So at the end of the maneuver, a drop-down menu comes. If everything happened well, as happened in this case, you just say no comments. But if there were things that the operator noticed and wants to put in, it's just one click to say for any one of these problems that happened. And if there's something that we missed, you can put in the free text. There's that option. The other thing we've put in here is that the operator has to have the ability to change a test that the computer has accepted to saying it's unacceptable. And then there would be a particular reason that would be in there for the operator. The other thing that we've got is standardized warning messages. Now, pretty much every system had its own little warning messages, and some of them were worded differently, and it varied from one system to another. So we've tried to standardize that as well, and to say what are some of the things that the computer analysis can find out and tell the operator and the patient so that it goes. So the ones that are highlighted in red are things that would make the measurements unacceptable. So if the back extrapolated volume exceeds the limit, what happens there? The rise time is really just we did not make this an error that would stop the make the effort not acceptable, because some people with muscle weakness and so on just can't initiate that flow really quickly. And however, if in for people that have a submaximal breath, one of the things that really is characterizes that is this long rise time. And so that's one of the things to look at. If there was no plateau and there was less than 15 seconds, those are the kinds of things now that would come in all the way through it. And we have a few more on the next slide. So if that big breath at the end is really important, and if they don't do the big breath, or if the big breath is submaximal, it's less than 90% of VC, that means that you probably haven't coached that maneuver well enough to get that person back up to TLC. And so that's a new warning message that would be coming in there. And if you have suspected glottic closure, well, of course, if the glottic closure would occur in the first second of expiration, that would be there. If the system detects glottic closure later on, that should also be a warning message that comes out to the operator. We spent a lot more time in this one looking at operator considerations and training. And as I've already mentioned, operator training, attainment, maintenance of competency has to be integrated and documented in the testing service. And recertification is recommended at least every 3 years. The previous guidelines said 3 to 5. And also, and this is also exactly come forward from the previous guidelines, is that recertification should happen after changes to lung function standards are published. And of course, we've just had some new ones in there. So one of the really important things that we also wanted to emphasize is that the operators is there not to just look at the equipment, but to look at the people. And so the operator has to have the right technical skill set so that they're using the equipment properly, they're taking care of it, they're working with that. But they also have to have a mindset for proper empathy, engagement, and motivation of the patient. Very, very important. So in these guidelines, one of the things that was a little different is that we did a survey of patients so that the guidelines could be informed by the patient population as well. And so an international survey was carried out by the European Lung Foundation of 1760 patients. And we got some data about that. And here were some of the things that, some of the more common concerns. 17% found the maneuver difficult, which it's low, but it's still important. If we looked at complaints, what did they, what they were concerned about? The biggest one was that about 38% report that they didn't get enough information, especially about things like withholding inhalers prior to the test. So this is really important. This may have happened maybe at the time that the test was ordered, but at the time the test is booked, and perhaps even just on the day before the patient comes, it would be good to remind them of that. Almost 10% of people reported feeling embarrassed about the test. Part of that is because, of course, you get the secretions that when you're pulling the maneuver in and out, or you start coughing, those sorts of things. It's you need to be aware of that, and you need to make the patient feel comfortable about that. The other interesting thing is about almost a third of patients rated being told to keep blowing even when they didn't feel anything was coming out as moderately or severely problematic. So when you're briefing the patient and describing the tests, it's really important to tell them that, you know, when you're getting to the end of expiration, it's going to feel that way. It's going to feel like nothing's coming out, but it's really important to us to measure that last little bit of air that's coming out. So even though we've got this really sensitive equipment, these spirometers, they can measure really low flow rates. And even though you don't think anything's coming out, there still is air coming out, and we need to measure it. So in terms of other patient considerations, we need to provide clear advice to the patients in advance of the test, let them know why they're doing it, and when they and whether they should discontinue medications and inhalers, and if so, which ones. The test should always be carried out in a quiet and private space. You should provide things like tissues and water. Water is really important for the cough. And it's giving clear verbal instructions to the patient before and during the procedure. And this is true even if the patient is experienced in doing spirometry. So other considerations are that between tests, you always ask the patient, are you ready before you do the next one? You don't rush them through it. You make sure that they're ready to go. If they've got to put a lot of effort into it, they've got to be ready for it. When you're talking about problems, you always use a no fault approach. You don't tell the patient it was their fault. You say, well, this is what happened. How can we do this together and do it better? And this is something that I think a lot of us were not really aware of, that the patient needs more time to recover after the testing session is complete. And some people felt fairly unsteady after sitting in the chair. So you ask them about syncope even before they leave the testing station, and perhaps make sure that they've got a place to sit and rest after they leave the testing station. So in my final slide, I've got some of the references that I've used and where you can get them from. So the standards for the 2019 update are published on both the ERS and ATS websites. So you've got the standards, but look at the online supplement. This is a really important part of it. We've got 46 pages. This is really a good teaching document. It's got lots of examples in it and goes into things in a lot more detail than we would have had space for it there. Also, the standardized pulmonary function testing report is available from that site. On the ERS is the full document on our results of the patient surveys and what the patient preferences are for spirometry. And the last resource is that I'd like to talk about is from RESPREC, which is an organization that I've worked with to develop a spirometry refresher course. A lot of the slides in this presentation are from that course. It's a 2-hour course. RESPREC is part of a not-for-profit agency. The 2-hour course that's offered here goes into a lot more detail. It's been accredited, and I would really, you can take this from anywhere in the world. It's got a nominal fee, $50. It's really cost recovery, and it goes into a lot more detail than I was able to go here. So while we're answering questions, I can just leave this slide up, I guess, Herman, so that we can, you can make notes of these.
Okay, thank you, Dr. Graham, for this excellent presentation, and also staying in time. So we have 15 minutes for questions. At the moment, there are 4 questions, so I would encourage all the participants to think of other questions. So the first question I received was about pain. Can you elaborate about pain?
Sure.
If there is pain at the end of spirometry due to coughing or going to a very extended expiration, is this a reason to end the spirometry exam? Okay, well, some of the examples that we've seen are, for example, there was a lady I had who had who'd had a concussion, and just the act of blowing was hurting her head. And of course, when that happens, when you've got pain while you're trying to blow out like that, you're not going to get a maximal effort. You're not probably going to blow right to the end, and it's not doing her any good. Other things are people that have had some kind of a chest injury, surgery that they've forgotten to tell you about, those sorts of things that can all cause pain. And it's usually related to those aspects. Now, yes, coughing can also cause some pain, and you need to deal with the coughing quite separately.
One of the things we've also found is that giving the water, getting people to clear their throat before they start the test can sometimes help with the coughing. But if you're feeling pain, and can also be, for example, lip pain, if you've got some kind of a lesion, perhaps even on the inside of your mouth that's giving you pain while you're doing this, or some people that have had an ear infection will get pain in their ear when they're blowing. Those are the sorts of things we want to avoid.
Okay, thank you. Another question is about handheld spirometer devices. They are, of course, on the market, and if they cannot meet the new ERS ATS 2019 standards, how should we deal with this? Speaking from
yes, that's a very good question. I think that unfortunately, within the standards, we were limited to 10,000 words. So we couldn't really cover the whole field. We had to concentrate on this. And so we decided that in writing these standards, we had to focus simply on attended spirometry. So this is spirometry being conducted by an operator. That's the intent of these. There is an important role for home spirometry. And I think that we really do need to have some separate standards for that. So certainly within the field of home spirometry, obviously the 2005 guidelines continue to be relevant there, perhaps more so than this. But I think I would really hope that we're able to develop some new guidelines for home spirometry in this regard.
Okay, thank you. I see now more questions. Very good. And there are two questions who look like each other, like how did you decide for the 15 seconds end of test criteria? And I recognize, of course, it's not the same about the repeatability. FVC should be within 100 milliliter of inspiratory vital capacity. Why not 150 milliliters? So it's more like, how did you took these numbers?
Sure. Yes. So the first question, the 15 seconds, the 2005 guidelines said 12 to 15 seconds. We went with, we decided we should have a hard number, so we picked the 15. 12 probably would have been my preference, but and again, it's been looking at some of the data, looking at where does it make a difference in this. And again, this is a committee, so this is an area that was in the expert opinion part of it, and looking at this, I don't think we've had any sufficiently good studies that say that if where we look at data that goes beyond 15 seconds and say if we would have stopped at 15, how would it have changed the patient's classification? And to get a large data on that would be tough, because then you'd have to have people who were quite obstructed and were a lot of people blowing out for 20 seconds to really answer that question from an evidence-based point of view. The second question about the inspiratory criteria. So why did we say that the inspiratory criterion was was 100 instead of 150? And the reason is we made it the same as the back extrapolated volume, which we also put down to 100. And that is because if you look at the back extrapolated volume, it means you didn't really initiate that maneuver. You could have leaked out 100 before you started. If you breathe in and reach a TLC that was 100 more than where you started, 100 mils more, then that really could be added to your back extrapolated volume. It's like starting your maneuver at a lower volume, and that's the reason we went with that criterion.
There was also one question, if you could show again the stopping times of the pre-medication again. And in addition to this, I recognize, being there for 20 years on the PFT lab, that sometimes I feel it should not be and that's a question to you, that you should always stop your medication for a spirometry test. So I have the feeling it could also give information what is the additional value
Yes.
to the already current, and you put it in the comments. And I'm a
So
little bit like protecting the patients, that they by definition stop it.
Yes, yes. So I think you're quite right. There can be two different reasons that you're doing this test. One is you do it to see if the patient was not having any bronchodilators and you give a bronchodilator, how does that improve their function? And so in that case, you do the withholding. But another reason for doing the test is that you're saying, well, under their current medication regime, could they be better if we gave them more medication? Have we bronchodilated them sufficiently with their current medication? In that case, you may not withhold the medication. The other thing, of course, is that we're not withholding the inhaled corticosteroids, and we also aren't withholding the leukotriene inhibitors. And so they can continue on that. The problem there, though, of course, is that you can have combination meds, and so with the combination meds, if they're including the bronchodilator, then of course, yes, you do have to withhold.
Yeah. So I recognize the guidelines are more, if you want to measure a maximum response in bronchodilation response, you should keep to these guidelines. That's
yes,
the
yeah,
goal.
yeah.
Another question also, what do you suggest about the reproducibility? So if there are all criteria about 2.5%, it's more about valid accuracy. And what about the reproducibility? And also when you look at the ISO standards, they also put both in, and they just copy like the 3% to 2.5%.
Yeah,
so what about
yes.
change over time? And I think it's related to biological quality control if you do this.
Yes, yeah. And so with the standards, yes, I mean, that's been another change. We moved to the ISO, and part of that was, again, that we had to focus our paper in one direction. The other thing, of course, is that the ISO guidelines are reviewed every 5 years, and they're adjusted every 5 years, whereas the ATS standardized waveforms hadn't been changed in a long time. And there were a couple of papers that suggested that that they didn't cover the full spectrum the same way, and that there were other waveforms that would give different results. And so that was our thinking in going to the ISO. In terms of looking at how does the spirometer itself behave over time and what are the changes. And so part of that was looking at the calibration factors. And so again, within the online supplement, what we've indicated in there is that if you have changes that are outside the usual sort of standard deviation of the measurements, then that would be an indicator that perhaps your spirometer is having other problems that need to be addressed separately. And you probably need to, that should trigger another action of reviewing the spirometer. Okay.
Another question: if a patient cannot exhale 80% of his vital capacity within the 15 seconds, is this going to be interpreted as a restrictive defect? Sometimes we have seen patients who took longer to achieve the 80% of vital capacity. If long volume tests are not bring down 50 seconds criteria might be misleading.
Yeah, I think that there are always going to be exceptions in this, and you have to look at the individual patient and judge on that. It's hard for me to understand how restriction would extend it beyond, would be beyond 15 seconds, because usually with restriction, it's the other way around. They're breathing out very quickly and it doesn't take very long. So, but with obstruction, that can happen. Also with muscle weakness, that can happen. And so that's really, the 15 seconds was really for people who just continue to blow out for a really long time, which is usually the obstruction.
Okay, yeah. If I would rephrase the sentence, it would be more about obstruction. I agree with this. We have 5 minutes left, and there are a few questions left. Can you explain more about the breath hold and how we can define between it and if a patient holds his breath? I'm not quite making.
Yeah. Okay. No. That's I think I can understand that, because it's really when they take that big breath in at the beginning, we want to have less than 2 seconds at TLC. Now that's again comes from the 2005 guidelines, but there was a nice study that was done on that, and it showed that if people the study that was done showed that if you hold your breath at TLC before you blow out, that does impact the FEV1 that comes out afterwards. And so, in fact, the effect is probably more for children even than for adults, but it's there. But the thing is that, and actually one of the things we found, and that has been seen, especially in some good clinical studies, is that too many operators will be afraid of getting their folks or getting the patient all the way up to the top. And because they're afraid that if they spend too much time breath holding, they'll start to leak, they'll get a big back extrapolated volume, or they'll exceed that 2 seconds. But the problem is that when they do that, they usually or often get the patient to blow out before they fill up. And that's what we want to avoid. So that's why we have to coach that patient to get up, up, up. When I'm doing my classes to teach people how to conduct spirometry, I often start by saying, just take a big breath in and keep your mouth open, like that, and then try and take a couple more breaths in. And most times you can get a little bit more air in, even though you think you're at TLC, you're not. And so coaching that, just coaching them to get all the way up and saying up, up, up. 2 seconds is a long time in spirometry. You can say up, up, up in less than a second and get them all the way up and then get that blast out. And so that's what's really important. And so I think and then that follows again right at the end. When you're getting that big breath in at the end, you still have to be just as enthusiastic about getting them up to full lung capacity at the end as you were at the beginning. And so, that's where you've got to maintain your enthusiasm throughout the whole maneuver. Get them all the way up, a maximum maneuver, really push it out, coach them hard right to the bottom, and then big breath in. And so, the emphasis goes all the way through.
Okay, thank you. I have a problem. I cannot ask you all the questions, but quickly I try to do a few more. If a patient can exhale longer than 15 seconds, is this a problem? Should we just stop?
I think that there would have to be a really good reason to push them beyond 15 seconds. And I think that on the initial initial test, for example, I would stop at 15 seconds. If the operator is looking at it and sees the person is perhaps right on the edge of meeting the the FEV1 FEVC ratio is right at the lower limit of normal, you might say, well, we blew out for 15 seconds. If they blew out for another 5 seconds, they might go below. That's rare. Usually if somebody's blowing out that long, they're already well below the lower limit of normal. And so I'm at a, I would find it difficult to think of the situation where blowing out for more than 15 seconds is something that would be ordered.
No. I think this will also point to the topic what you are, of course, heavily involved with, this standardization. If one PFT technician on the lab is doing this and the others is not doing it, I think it's good that they talk to each other, and now we can do because otherwise the physician will see difference in vital capacities due to this.
Yeah.
Let's try the last one, and I think you will receive all the questions and you can answer them by email afterwards. So I already apologize to the questions I was not able to. And this is, I think, and the second question to the first question already raised. What is the significant change in FEV1 and FVC over time? What do you see? Like, And it's always, and of course I have to apologize. I like this kind of questions because I
Yes.
think trending is the most important
Yes.
thing in the PFT. It's nothing about this one. And there's always a struggle. When is there really a change or not? And that's
Yes.
the question about in 3 months,
Yes.
in 1 year.
Yes. So that is a question for the next set of standards that are coming out.
Okay.
And that is the interpretation standards. And so the interpretation standards will be out very shortly. And that's one of the aspects. But we, in these standards, did not deal with interpretation. We dealt with the standardization of how you do the maneuver more than anything else. That was our main part of it. The I certainly do agree with you that the change over time is really important. And of course, as we've seen within the global COPD and the global asthma guidelines, well, the global COPD especially, that's where you see the attention being paid to that. And so, yes, there is a lot of research being done on that, but I think within our standards, within the standards of doing the tests, what we can do is to say that if you're making these measurements over time, at least you've got more confidence that you're measuring the same amounts over time, and that the difference you see over time is not due to changes in the equipment or changes in anything else. It really is changes in the patient. And that's the whole point of standardization, is that you try and take away the variation in the equipment and the maneuver and the techniques as much as possible, because that's a big factor in the differences you measure in lung volumes. And so the effect of the operator, the effect of the equipment, how the patient behaves, are all going to be huge factors in that. So if you're trying to say what's happening to the physiology and the pathology within the patient, you want to keep that to a minimum, and that's why we have standards.
Thank you. And yeah, due to me, we have 5 minutes extra, not to you, because you were exactly on time in 45 minutes. A big thank you from my side. And I know we could go on for another hour with all the questions, but hopefully we will find another time to do the next meeting, and maybe it's about then the new standards about interpretation. Thank you.
Okay,
and thank you all the attendants to be here still after 1 hour and a few minutes, and hope we will see you back in 1 month about broncho challenge testing, and all the webinars will come in the next year. Thank you.
Thank you.
Bye.
Bye.
Bye.